We have been speaking about sympathomimetic drugs, such as epinephrine. And we will be talking about the sympatholytics or blockers. But before we do, we had learned that the acetylcholine receptor sites on our visceral organs, like our heart, are different from the acetylcholine receptor sites on skeletal muscle. Those on our heart and other internal organs, and also in our brain, are called muscarinic acetylcholine receptor sites. And so there are drugs that activate and block muscarinic acetylcholine receptor sites. The receptor sites, the acetylcholine receptor sites on skeletal muscle, are called nicotinic acetylcholine receptor sites. So the drugs that activate or block those nicotinic acetylcholine receptor sites on skeletal muscle, they don't work on the muscarinic acetylcholine receptor sites on the visceral organs. So that's why we've got drugs that can affect skeletal muscle that don't necessarily have any effect on the heart, and we have drugs that affect the heart that don't affect skeletal muscle. Well, we had also alluded to this idea that the adrenaline receptor sites that are on our visceral organs, like our heart and our stomach and our airways and our liver, they're not all the same. In the 1940s, they learned, using different drugs, that there were so-called, what they called Alpha-Adrenergic receptor sites and Beta-Adrenergic receptor sites. And then later, in the, this is actually not 1940s, but 1960s, in the 1970s and 80s, they learned that they could further subdivide them using different drugs into alpha-1 and alpha-2 and beta-1 and beta-2 and beta-3. So now this whole subject of receptor sites and different medications has gotten a lot more complicated. Now the reason why they want to be able to do this is because if you give somebody epinephrine, I'll just remind you that epinephrine is going to cause everything listed on page C21 on the right-hand column. But if we can just activate or block the beta-2 adrenergic receptor sites, or just the beta-1 adrenergic receptor sites, that means we can zero in and just affect certain organs of the body and not have them affect other organs of the body. And the advantage of that is that if you only affect the organs that you really want to affect, you don't have all these side effects, all these other actions. So epinephrine is a wonderful drug, but if you're giving it to raise blood pressure, it also raises blood sugar level, it also dilates airways, it also decreases salivation and GI motility, and it just does so much that we don't necessarily want to have it do all that stuff. So that's why there's been all this emphasis in trying to reduce this. Now, let me also just point out to you that on page D27, so we're going to be learning this D27. We're going to be mentioning some of these so-called alpha and beta adrenergic drugs. And you'll notice that in this chart in the middle of page D27, so it shows that epinephrine, right here, epinephrine, and it says alpha and beta, and it says it's 50-50 for alpha and beta of epinephrine. And you'd say, what does that mean? That means that epinephrine activates both alpha and beta adrenergic receptor sites. It activates all the adrenergic receptor sites. You'll notice that other drugs that are listed here, such as levonorepinephrine, and you might have heard of levonorepinephrine under the brand name neocobephrine. Does that ring a bell? There's actually a local anesthetic that contains as a vasoconstrictor neocobephrine in it, which is a brand name for levonorepinephrine. And you'll notice that it shows it has a ratio of 75 to 25. And if you're thinking, like, what does that mean? That means it's 75% mostly alpha effects, 25% beta. You'll notice that there's another drug right up here, phenylephrine, and that's 95 and 5, meaning it's 95%, almost 100% alpha, 5%, almost 0% beta. But I guess the main point I'm trying to make is this. We don't, even when we have a drug that's called an alpha-adrenergic drug or beta, it may be 95% alpha, but that doesn't mean it has 0 beta effects. It's just very little. So it may have some it may slightly activate or block even the beta-adrenergic receptor sites, even though it mostly acts on the alpha. So again, this just shows you the subtleties of these drugs. But let's go back to D11. What is an alpha or a beta-adrenergic drug? And so I'm going to try, this is something I invented on my own, so I'm expecting to win the Nobel Prize for this, but I'm not going to hold my breath. Again, this is a complex subject, and I'm going to try to lay this out in as simplified way as I can. Obviously, when you simplify, you do make it simpler, but you also leave out some of the details as well. But that's okay. All right. So I'm drawing a whole circle here, and basically I'm drawing an arrow, and I'm going to write parasympathetic. Parasympathetic. And then I'm going to draw another arrow here, and I'm going to write sympathetic. So we know that our nervous system can activate parasympathetic actions on our internal organs of our body, and it can activate sympathetic actions on our body. We've also learned that there are drugs that can mimic either the parasympathetic or sympathetic, or block the parasympathetic or sympathetic. The parasympathetic, of course, just to remind ourselves, is the rest and digest state. And the sympathetic is the stress state, using either F words or E words or whatever we want to use. Stress. We have learned that there are drugs that can mimic the parasympathetic and cause that to happen. And we've also learned that there's drugs that can block the parasympathetic. And a specific, and generally I don't ask you to know names of drugs, just concepts or categories. But this word, this name of a drug, atropine, is worth knowing. That is a classic, prototypical parasympatholytic drug, a drug that blocks the parasympathetic. And if you block these, all these acetylcholine receptor sites on the visceral organs, which is what atropine does, then by default, right, you block this, so by default, the body goes into this sympathetic or stress mode. Now, I want to remind you that if we go back to page C21, C21 is our chart, and so we're focusing now on this sympathetic, and we told you that epinephrine, sympathetic motor, autonomic motor neurons, and epinephrine activate all this junk. Now, we now know that some of these adrenaline receptor sites are called alpha-adrenergic receptor sites, others are beta. And the main thing I want to draw your attention to is blood vessels for a moment. Because we had learned that here, epinephrine causes most blood vessels in our body to constrict by activating the alpha-1 adrenergic receptor sites. But epinephrine actually dilates the blood vessels to the heart and skeletal muscle by activating beta-2 adrenergic receptor sites. Epinephrine does both. All right, so it's written right there on C21, so you're going to understand what I'm doing here on D11. So on D11, let's subdivide this. What is the alpha and what is the beta? Okay, here's our symbols for alpha. Now, I like to mention the alpha because really, most of the receptor sites, most of the adrenaline receptor sites on our body are beta. there are many fewer alpha-adrenergic receptor sites. Where are the alpha-adrenergic receptor sites? They are on the eyes. They're basically on the eyes, and they are on most blood vessels. Most blood vessels, but not all blood vessels. So most blood vessels have alpha-adrenergic receptor sites. Now, where are the beta-adrenergic receptor sites? The beta-adrenergic receptor sites are basically everywhere else other than the eyes and most blood vessels. So I'll just write everywhere else. All the other organs, internal organs, everywhere else. It's not very, I don't think pharmacology books would write it that way, but we'll say everywhere else in the body are beta-adrenergic receptor sites. And just to remind you, not only does everywhere else include the heart, it includes the liver, it includes fat cells, it includes the stomach, but it also includes blood vessels. It also includes blood vessels to the heart and skeletal muscle. Now, epinephrine activates the alpha and the beta. Let me just write it. I'm going to write epinephrine here. Right here. I'm going to put epinephrine. I'll just write epi for short, just to remind us. So epinephrine activates all these adrenergic receptor sites, alpha and beta. So it has the epinephrine causes the sympathetic effects on the eyes, and it causes the sympathetic effects everywhere else in the body. Epinephrine both affects most blood vessels in our body. And what does it do to most blood vessels? It causes vasoconstriction to most blood vessels. So epinephrine constricts most blood vessels of the body. How? By activating the alpha-adrenergic receptor sites, which are on most blood vessels. But epinephrine also activates the beta-adrenergic receptor sites on the blood vessels of the heart and skeletal muscle. And when epinephrine activates these so-called beta-adrenergic receptor sites on the blood vessels to the heart and skeletal muscle, what do those blood vessels do? They dilate. So epinephrine does both. It constricts most vessels, but dilates those to the heart and skeletal muscle, because on most vessels they have alpha-adrenergic receptor sites, but on the blood vessels to the heart and skeletal muscle they have beta. Okay, great. I am not going to subdivide the alpha any further. We now know there's really alpha-1 and alpha-2. I'm not going to get into that. But it is important for me to further subdivide the beta. So they discovered more recently that we can divide the beta into beta-1 and beta-2. And there's really also a beta-3, but we're not going to deal with it. So beta-1 and beta-2. Now, where are the beta-1 mostly located, and where are the beta-2? I'm not going to list every place. I'm just going to tell you the most important. The most important places where the beta-1 adrenergic receptor sites are the heart. So usually when we're talking about a drug that either activates or blocks beta-1 adrenergic receptor sites, what we mean is it's activating or blocking the adrenaline receptor sites on the heart. And the most important place for beta-2 are the airways. So if we're talking about drugs that activate the beta-2 adrenergic receptor sites, we mean that they activate the adrenaline receptor sites on the airways, And what effect does epinephrine have on airways? It dilates them, right? It constricts blood vessels, but it dilates airways. So we're just going to write that to remind you, bronchodilation. And just to remind you of what beta-1, what effect does epinephrine have on the heart? Epinephrine causes the heart rate to speed up. Let's just remind you of that. That's tachycardia. Increased cardiac output. Just to have that in mind. Now this is my scheme. All right, so this is really keeping it simple. So overall, I don't know, I probably should have drawn out the whole thing so you could see it. I could have actually drawn it out for you and you wouldn't have had to draw anything. But I kind of made, so this is kind of a branching diagram. Now I'm going to develop this further, but before we leave this page, because we're going to use this in like a little reference page as we talk about things, I just want to add 2 more drugs here. So we wrote epinephrine right above sympathetic, and I'm going to write after epinephrine the drug ephedrine. And maybe you've heard of ephedrine or not. And then I'm going to add 1 more drug. And I know one of the problems is, but I didn't leave space. I understand it. Sometimes I don't either. But I'm just going to add 1 more, amphetamine. Because as we're going to see, ephedrine and amphetamine are really just more potent versions of epinephrine. And we've all heard of amphetamines. I've mentioned being on methamphetamine or speed. Being on speed is like being on high-powered epinephrine. Okay, so this is our simplified diagram of a complex subject. So the first thing we're going to look at is we're going to look at the alpha, drugs that activate the alpha-adrenergic receptor sites. And basically, drugs that activate alpha-adrenergic receptor sites are going to have the sympathetic or adrenergic actions on the eyes. And what does that include? What is the adrenergics, the sympathetic action on the eyes? What does sympathetics make the eyes do? Dilate. We'll call that mydriasis. And it's going to cause most blood vessels in our body to constrict. That's really what alpha-adrenergic drugs do. They make pupils of the eyes dilate and also increase intraocular pressure, and they cause blood vessels to constrict. That's about it. That's about all they do. So with that in mind, look on the next page, D12, and it says alpha-adrenergic agonists. Now we have learned that an agonist is a drug that activates a receptor site as opposed to an antagonist that blocks a receptor site. So our prototype, and I'm not so much asking you to remember names of drugs, is neosynephrine, those nose drops. And so what is the pharmacodynamics? What do these drugs do? They activate the alpha-adrenergic receptor sites. That's it. And if you can remember that the alphas are on the eyes and most blood vessels, that's all you really have to know. The most of the clinical uses of alpha-adrenergic agonists are based on its vasoconstrictor action. I presented it so that it really has just 2 actions. It makes your pupils dilate and it constricts vessels, and most of the clinical uses for alpha-adrenergic drugs is based on the fact that they constrict most vessels. Now, why would you want to constrict vessels? Why would you want to give a patient that? Because if you constrict most vessels, we'll just remind you, if you cause generalized vasoconstriction, will increase total peripheral resistance. And that will increase blood pressure. And if you're thinking, didn't you say something about this earlier today? Yes, I said it multiple times today. All right, so constricting most vessels raises total peripheral resistance and raises blood pressure. So why would you want to give this drug? For people with hypotension. What's hypotension? Low blood pressure. And an example, there are many causes of low blood pressure, but one that is certainly relevant to you is something called postural or orthostatic hypotension. You heard of that? Now this, some people can have it even when they're young, but it becomes more common as people get older. It also becomes common because of various other medications they're on. So why it's called postural or orthostatic hypotension is as long as they're lying down or sitting in a chair, they're okay. But when they stand up, gravity pulls the blood down to their feet, and the blood pressure to their brain drops, and they feel like they're going to faint, and they might faint. So normally when we stand up, and we've all stood up on occasion very quickly when we started to feel faint, normally we don't faint because our blood vessels constrict, raising peripheral resistance, and that raises our blood pressure. Just put it in a battery here. So that's normally what happens. But in these people, their blood vessels are not constricting like normal, and therefore their blood pressure isn't going back up like normal. And so what they're doing is they're giving them a drug that constricts vessels to help maintain their blood pressure. So this is very common for people with orthostatic or postural hypertension to put them on a vasoconstrictor drug, an alpha-adrenergic drug. Now, some of you, from what I said earlier today, may be thinking, he talked about this earlier, didn't he say that if you cause if you have a drug that constricts and it raises peripheral resistance and that raises blood pressure, didn't he say earlier today that somehow your control center in your brain causes your heart to start slowing down if you do all this? Yes, and in fact, under adverse effects at the very bottom, one of the adverse effects is that it causes a reflex bradycardia. That's exactly what we said earlier. Now again, I don't want you to think, boy, I'm going to test you on that and I'm going to hammer this. This is like, in many ways, more detailed than you need to know. But I'm just explaining that in case you thought that this is an example of why I spoke about what I did earlier today. Anybody on this kind of drug is going to cause a reflex slowing down of their heart rate. Remember, generalized vasodilators like nitroglycerin cause reflex tachycardia, speeding up of the heart rate. Drugs that are vasoconstrictors, like this category of drugs, cause reflex slowing down of the heart rate, or bradycardia. So what I said earlier applies to this class of drugs. That's why I mentioned it. But why else would we use alpha-adrenergic drugs which constrict? They're used as nasal decongestants. Thus, neosynephrine nose drops. You squirt them up your nose, they constrict the vessels in your nose and the vessels to your eustachian canals, and that's used to reduce vasocongestion and the mucus and the fluid and the swelling and all that. So it's used, they use these as nose drops and so on for rhinitis. Rhinitis is the clinical word for colds, and hay fever, and sinusitis, and otitis media, middle ear infections, because it reduces by constricting the vessels in your nasal passages, it reduces swelling and congestion. And they use it as a local vasoconstrictor. There are some local anesthetic preparations that instead of using epinephrine, use an alpha-adrenergic agonist. Now, and does that sound like a worse idea or a better idea than using epinephrine? It's actually a better idea, because all that it does is constrict vessels. It can cause the reflex slowing of the heart rate, but remember, epinephrine does everything. Everything. And it's better to use drugs that do less, that are more selective than drugs that do everything. So it would be better to use an alpha-adrenergic agonist rather than epinephrine as a vasoconstrictor. Now, let's just, I'm not going to get into all this detail, and I'm certainly not asking you to memorize all these different drugs in any kind of detail. On D13, one of the, just to explain, one of the cautions of this drug is glaucoma. And why glaucoma? Glaucoma is an increase in intraocular pressure. These drugs have two effects. They cause most vessels in the body to constrict, but they also produce the sympathetic effect on the eyes, which not only includes dilating the pupils, but an increase in intraocular pressure. I'm just explaining why it should be used with caution for somebody with glaucoma. All right, there are all kinds of brand names for this. Neosynephrine, Midrifin, Nasop, Rhinal, Sudafed PE, which stands for phenylephrine, Vicsinex. And you'll notice if you're thinking, well, why is this in the Sudafed and Vicsinex as a decongestant? It constricts the vessels in the nasal passages, and that's called a decongestant action. That's the word we used on the previous page, a nasal decongestant. So these are commonly used as nasal decongestants. Now, there are a whole bunch of other drugs in this class, this category, besides phenylephrine or neosynephrine. There is a drug called levonorepinephrine. It goes under a brand name neocobephrine. There is a local anesthetic preparation, and I believe that the name of it is carbocaine with neocobephrine. Has anybody ever seen that? Carbocaine with neocobephrine. And what is neocobephrine? That's the brand name for an alpha-adrenergic agonist, a vasoconstrictor. It uses this kind of drug to constrict the vessels rather than epinephrine. So we'll repeat the question. So is that a worse idea or a better idea than epinephrine? It's actually a better idea. It would be better if they used drugs that just constrict vessels rather than doing lots of stuff like epinephrine. Why don't they do it? Well, there's a whole lot of things we could ask. I've asked you previously, why is it okay to put benzocaine topically if it's an ester local anesthetic? And nobody has ever given me a good answer to that. If you're that worried about ester local anesthetics. So there's a lot of things where I don't know why they do. Frankly, you don't even need to use any epinephrine. You could just use a 4% mepivacaine solution, right? And then you don't have to worry about epinephrine at all. And in fact, that's what they suggest you do for anybody with a history of heart issues, right? So anyhow, I don't know. There's another alpha-adrenergic agonist. Again, I'm not asking you to know names of drugs whatsoever, called methoxamine. It goes under a brand name Vasoxyl. Just from its name, Vasoxyl sounds like it might have a vaso effect. It constricts, blood vessel, it constricts vessels. Okay. That's all I'm going to say. All you have to know. What's the bottom line of alpha-adrenergic agonists? Alphas cause pupils to dilate and cause vessels to constrict. Is that okay? And then they use it for various reasons why they might want to constrict vessels, like for people with postural hypotension or nasodecongestant or whatever. Now, let's deal with betas. Betas do all of the sympathetic actions except they have no sympathetic effects on the eyes, and the only vessels they affect are the blood vessels to the skeletal muscle and heart. They make the vessels to the heart and skeletal muscle dilate. They do not constrict vessels at all. That's the betas. So on page D13, the beta-adrenergic agonists. Again, I'm not asking you to know names of drugs. Isoproterenol is an example. Okay, so the beta-adrenergic agonists are drugs that activate just the beta-adrenergic receptor sites, which are really the majority of them. Now, let me refer us back to D11. So we said that the betas activate all the adrenergic receptor sites in the body. That certainly would include beta-1 and beta-2, wouldn't it? right? Those are just subcategories of the beta. In other words, a beta-1 and a beta-2 are betas. So that means that a beta-adrenergic drug is going to increase what the heart does, and it's going to dilate airways, as well as all the other stuff. So most of the uses of the beta-adrenergic drugs is either to stimulate the heart or to dilate airways. Those are its major uses. It is going to create the sympathetic affections everywhere else, including increasing blood sugar level and doing all the other sympathetic actions. We've talked about decreasing GI motility, but the main clinical uses of beta-adrenergic drugs are as cardiac stimulants and bronchodilators. So, on D13, that's exactly what we wrote. The beta-adrenergic drugs, which activate the beta-adrenergic receptor site, their principal clinical uses are used as a cardiac stimulant and a bronchodilator for various breathing problems, including asthma. So again, my simplified diagram is intended to take complex subject and really distill it down to something simple. On D14, just to mention, again, this is not stuff I would test you on, but you might ask, well, why is it going to cause flushing of the skin? Because beta-adrenergic drugs will dilate the vessels of the heart and skeletal muscle, and sometimes it may even cause some dilating even in the skin, and that's why you see flushing. Anyhow, again, our focus, this is not the most important group of drugs. I'm going to tell you the more important ones, but we're certainly mentioning them. It goes under a lot of brand names. There are other beta-adrenergic drugs, including one called isoxaprine. It goes under a brand name Vasodilan. Now, didn't we say that a beta-adrenergic drug will dilate the vessels to the skeletal muscle and heart? It doesn't constrict any, it only dilates. Epinephrine constricts most vessels, dilates those to the heart and skeletal muscle. This only has the effects on the beta sites, which is dilating. So notice the brand name, Vasodilan. Isn't that cute? And what is it used for? Raynaud's disease. Who's heard of Raynaud's? What's Raynaud's?
It's where the fingers like turn white.
They turn white because of poor circulation. The vessels are very sensitive and they constrict. And so wouldn't it be useful if you gave them a medication that dilated vessels? Remember, this drug only dilates vessels, it doesn't constrict any vessels. So that's why they use this drug, Vasodilan, for Raynaud's disease. Now, let's again remind you of our chart. So, we have mentioned these all-purpose beta-adrenergic drugs that are primarily used as cardiac stimulants, bronchodilators, or to dilate vessels, but it does all these beta effects. Now let's just mention beta-1 and then beta-2 adrenergic drugs. First, those drugs that just activate the beta-1 adrenergic receptor sites on the heart, and then we'll look at those that activate just the beta-2 adrenergic receptor sites, which are primarily located on the airways, although they're also on the blood vessels that dilate. So the beta-1, there is a drug called dobutamine or Dobutrex. I'm not asking you to know the name. And it's used as a cardiac stimulant. That's a beta-1 adrenergic drug. And they stimulate the heart for people with congestive heart failure, CHF. Now, an important group of drugs, really a group of drugs that many of you are already familiar with, are the beta-2 adrenergic agonists. And an example, a prototypical example of a beta-2 is the drug albuterol. It goes under a number of brand names, including Proventil and Ventolin. All of these beta-2 drugs, we said, basically are bronchodilators. That's their main use. So they're all used as bronchodilators to control, to manage respiratory problems like asthma, bronchospasm, bronchitis, and emphysema, but especially things like asthma. If you know of somebody who has asthma, then the drugs that they are most likely taking are these bronchodilators, which are technically beta-2 adrenergic drugs. They simply activate those beta-2 adrenaline receptor sites on the airways and dilate the airways. Some other examples on D15. Let me get to it. All right, these drugs can be administered by inhalation or taken orally. Notice what I wrote about adverse effects. Essentially none. And you might say, well, how could there be almost no side effects? Because these drugs that activate the beta-2 primarily just activate airways to dilate. Epinephrine does everything in the body. Epinephrine activates the whole sympathetic response, but a beta-2 adrenergic drug is a drug that causes airways to dilate. Now, we'll have a few other effects. We did say that dilating blood vessels is also beta-2, but its main clinical use is to dilate airways. That's its main use. Back on page D15, so there are a whole bunch of other beta-2 adrenergic agonists. Another one is Ceravent. And the main difference between albuterol and Ceravent is something you take just twice a day, BID. Albuterol, for people again who have asthma, albuterol is something when they start to get an asthma attack, they'll inhale albuterol. It's a very immediate onset, immediately helps them, but its duration of action is short. The effects only last maybe an hour, maybe less. Whereas this drug, it takes a little bit longer for its effects to occur. It has a longer onset of action, a delayed onset of action, but it has a much longer duration of action. So they only have to take it once or twice a day. So this is for somebody with chronic asthma where they get it all the time, so they don't want to keep spraying with these short duration bronchodilators every half hour, so then they take something, they inhale it once or twice a day. So this difference in how the duration of action is this pharmacokinetics idea. Pharmacokinetics, so albuterol and Ceravent have the same pharmacodynamics, they have the same effect, but their pharmacokinetics are a little bit different as far as duration of action. Advair, many of you either have taken Advair, know of somebody who takes Advair. Advair is a combination. They inhale it into through their mouth, and it's a combination of Ceravent, what we're speaking of, a very long duration bronchodilator, and fluticasone, or Flonase. Now, Ceravent is the beta-2 bronchodilator with a long duration of action. Flonase is a corticosteroid. That's a corticosteroid. And what they found is that people with chronic asthma, not only do they have constricted airways, but they've got chronic inflammation in their airways. So they are giving them a corticosteroid, which is an anti-inflammatory drug. So they're giving them both a combination bronchodilator and anti-inflammatory. So that's what Advair is. I'm sure many of you have heard of this stuff. That's very commonly used. There are a whole bunch of others. Again, our intention is not to have you memorize lots of drug names, but to understand categories of medications and why they might be used. You're not going to remember all this, but if you ever have to look it up, I think you'll immediately remember what that was. Some of these have really cute names. You'll notice this one, these are all used as bronchodilators, has a brand name Maxair. Sounds like it maximizes your air. And this one has a brand name of Breathair. Isn't that cute? Breathair. Now, all right, so to summarize, going back to page D11. So on D11 so far, we have been talking about first the alpha, the drugs that activate the alpha sites, and the drugs that activate the beta, and more specifically just the beta-1 or the beta-2. Now I want to come back up here. Now epinephrine activates the full-blown sympathetic response. And epinephrine is injected into somebody with an EpiPen for anaphylactic shock. Epinephrine could be given IV drip or intravenous injection as a cardiac stimulant or anything like that. But we know that epinephrine cannot be swallowed and taken orally. Because it's a catecholamine, and because there's an enzyme called catechol-O-methyltransferase that breaks apart catecholamines like epinephrine in our digestive tract, if you needed something like epinephrine but you wanted to swallow it, you can't swallow epinephrine. So what we have is ephedrine and amphetamine are orally active. These are called non-catecholamines. They are non-catecholamines. Epinephrine is a catecholamine. These are non-catecholamines. That means they're orally active. You can take them orally. And certainly, everybody has heard of swallowing amphetamines. Dexedrine, speed, methamphetamine. So these are orally active. Now they're also listed for a certain reason in this order. As you go from epinephrine, which has to be given parenterally, either inhaled or injected, then to ephedrine, which can be taken orally, to amphetamine, these are listed in increasing order of CNS stimulation. So they are listed in increasing order of central nervous system stimulation. So if epinephrine makes you more alert, ephedrine really makes you more alert, and amphetamine really wires you. So these are listed in increasing order of effects on the brain. Now they all are going to speed up heart rate. They're all going to produce the full-blown sympathetic response. They're all going to speed up heart rate. They're all going to raise blood pressure. They're going to dilate airways. They're going to raise the blood sugar level. But these are also having more and more effects on the brain. So what we're going to see is that amphetamine isn't really used as a cardiac stimulant or as a bronchodilator. It's primarily used for its CNS stimulating effects. All right, but these are all related. All of these drugs are just related to epinephrine. Their chemical structure is very similar.